Testing 1 2 3. Testing 3 2 1.
Good morning, everybody. The Finance Committee will come to order. Any citizens in attendance wishing to address the committee? You're seeing or hearing none. We'll move on to item 3, approval of the minutes from August 26th meeting. I'll entertain a motion.
Move approval of the minutes from August 26th meeting.
Motion by Ms. DeBose. Second by Mr. Zimmerman. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you very much. Move to item 4, CFO report. Ms. Clark.
Good morning.
Good morning.
Morning.
I had planned to do a supply chain update, but we're working on a couple of the savings numbers, and I think it will be more meaningful if I bring that back next month, because it's just a periodic update for the committee. So we will talk about that in October. And also wanted to remind everybody that we are approaching yet another fiscal year end. So we've got about 2 weeks left in the fiscal year, which, just as a reminder, is September 30th for JPS. The audit will begin in about 3 weeks after we close. So field work starts about October 25th and continues through Thanksgiving. And the Finance Committee will be brought back the final audit, and Chris Clark, our partner at BKD, Robert always says no relation, will be here on the December 16th Finance Committee. So we'll have another year wrapped up. I will spend a bit more time next month on just kind of the final fiscal year results, and we'll be looking at the year-to-date number and how we kind of wrap up the year. So more to come on that, but it's a good year. So that's all my prepared comments.
Okay. Any questions for Ms. Clark? Okay. Thank you very much, Sharon. And you'll bring the supply chain next
Yes.
committee? Next
Yes.
Finance Committee? Okay, great.
I'll just incorporate that into my year-end report.
And your audit season's your favorite time of year besides budget?
You know, it's hard to beat a budget, but yeah, that's
Yeah.
got to be a good second runner-up.
There you go. All right, we'll move to item 5. Yes, sir.
What's included in supply chain?
Like as far as people or function?
I mean.
So it's really, it really, although supply chain is not responsible for all RFPs, the supply chain function begins with the looking for goods and/or services. Supply chain does a lot of not only ordering, we manage the warehouse, we manage the stock rooms on the floor. We partner with a lot of functions throughout the hospital that are highly specialized. For example, we don't do pharmacy, but we do work with them. We've just started to really, post-COVID, started to get into respiratory therapy supplies when those got difficult to source. So every week, we look at what we're needing, we place an order. We're notified on Monday or Tuesday whether that order is going to be fulfilled during the week. And we also have to find alternates, which is becoming more the norm. And you just have to get in anything from cups to tubing to saline, bags, syringes. It's pretty all-encompassing. You bet. So this month we did see a little downturn of admissions. We were about 15% under, and it's been about a quarter since we've had that low of admissions. We did have a little uptick in our length of stay and a little uptick in the CMI, which measures the acuity of the patients. Last month, someone asked, were the COVID patients really at a higher CMI. And I do have those numbers this month. Just for reference, year-to-date CMI is 1.81. The non-COVID patients are around 1.79, and the COVID patients are almost 2.3. So it doesn't sound like a huge differential, but every 1/10 of a point on the CMI is substantially a sicker patient. For the emergency department, those have remained fairly constant month to month. We're about 9% under our target or budget for this month. And we did see a little bit of an uptick in urgent care, but still about 12% under where we expected to be. Our clinic visits on the right-hand side of the page, we continue to encourage telehealth where it works for patients, but we have opened up schedules again. So we're kind of leveling off at around a 10% telehealth mix compared to a face-to-face. On specialty, that telehealth is just a little bit higher at about 15%, but well over budget, both in primary and specialty clinic visits for this month. Towards the bottom of the page, if you look at our surgeries, we have, with the spike in COVID, started to evaluate surgeries a little differently. So you see a downturn in our inpatient surgeries. Although we've been under budget most of this fiscal year, we were about 20% under for the month. And you can see a sharper downturn in our outpatient surgeries. They are about 11% under, but have been over for about the last 6 months. From a mental health standpoint, our patient days remain very close to budget. Year to date, we're only about 6% under in our inpatient days here. Our clinic visits remain fairly strong. And you'll note that we have about a 35% telehealth mix in mental health. And then on the emergency visits, our PEC, which is the Psych Emergency Clinic, we have all year pretty much consistently been above where we budgeted and above the prior year. We're about 15% over just for this month, and about 11% over year to date. So the financial metrics, days cash on hand. The left-hand side, just as a reminder, does not include what we've already set aside in the future fund. But what we have available for operations, there's a total of 339 days. It's a natural trend as we start to use some of the cash that comes in from our largest payments in February and March for some of our ad valorem or property tax revenue. But about 44 of those days are still our CARES Act monies that we have on our balance sheet. And I'll bring back more next month to let you know what we are planning to recognize, and then that will move from the balance sheet on into available operating cash.
Have they given guidance yet of how and when we can recognize that?
It is ever changing. So the latest update is we can evaluate by quarter. We don't have to look at it year to date. So over the next couple of weeks, we will estimate a number, and hopefully we'll continue to get guidance, but during the audit, that'll be a full 6 to 8 weeks later. So my plan is to estimate what we are going to recognize, and then BKD will help us solidify those numbers through mid-November. So we should have a really solid estimate. My hope is that they will continue to revise these favorably for hospitals to be able to recognize and keep these dollars. And they may also extend the recognition period. At the moment, I believe it ends at the calendar year end. So that's great. Roger and I are happy with the ring.
He's purposely taking his time on that.
Thanks, Sim.
In college, professor used to answer the phone.
My college, they sent me away.
So,
I'm feeling nauseous now.
but honestly, that's like the one big question is the CARES Act recognition for our year end. And I'll point out on the income statement, it does get recognized below the line, and I think I've lost my audience. So we'll talk about that next month. Our net AR days continue to hover pretty close to the same number all year. We ended the month at 44 days, which represents kind of the average time it takes us from the time we drop a charge to the time we actually close the account and consider it collected. There are some that are open for 2 years, and there are some that we can close within 15, 20 days. So it's a wide range, but 44 is a great average. We continue to be favorable on our FTEs per adjusted day number. So we're at 5.85 compared to a budget of 5.96.
Sharon, I'll ask a question, and it's actually in regards to the positive and negative boxes on the previous slide. Are those where it's red and green? So psych patient days is currently red. Is
Yes.
that for the lagging 12 months, or is that the current?
That is for the current month.
Okay.
So the boxes, and those are favorable or unfavorable.
Okay.
So some of them are over and they're green, some of them are under and they're green. So it's really kind of our interpretation that we didn't hit volume, so the patient days box is red for the month. Outside medical services is under, but we actually have some financial savings from being able to keep those patients in-house and not having to use our community partners when our beds are full. So that's a favorable variance for us.
Okay. I wish there was a way to see, anytime in financial statements, the period could be unfavorable, but the whole picture is favorable.
If the committee would like, we can make that change in September and keep those boxes a year-to-date number versus the month number.
I mean, I don't mind seeing both. It's good. Yeah, great. For the month of June or July,
I will figure
we're red or
that
green,
out.
but for the year, we're, either way.
Yeah, it would seem to me.
It is at this point, yes, I agree. Yep, we will figure out how to make 2 boxes. And I always welcome comments. This is really your financial presentation, so if there's something that makes more sense to you guys, please let me know. Our connection enrollment has kind of leveled off this year at around 42,000. We do continue enrollment activities, and the bigger decrease in February was our overall re-enrollment for quite a few of our participants that we had extended that time frame for and not made reapply during the COVID period.
Why it's sort of leveled off, because we were trending up, and I realize why it goes down that particular month, but we still haven't recovered much.
No,
Are we
and
same recruiting efforts and all that kind of?
it is. And there are, it wasn't just a one-time renewal. We have each month. If you have been renewed more than 12 months, you're up for renewal on that month. So we've got a lot of, people who may have been extended for 18 months that ended in February, that ended in March. So there's a big churn that you may not see in these slides. We have a lot of people that roll off, and we have a lot of people that are enrolled and approved. So I think it's just, it might kind of hover here and look flat, but we're still continuing to enroll people It's just that we have several months and several periods of extensions that are hitting us pretty heavy
Right,
on
got it.
the
Okay.
rolling off.
Is there any way that when we look at this, you can see new connection patients versus the one that are returning?
I can change this from more of a graph to maybe more of a grid, kind of showing, members that have rolled off versus members that are rolling on. So you can kind of
Yeah.
see,
I'm kind of seeing if we're
The
picking
up
up
and
any
down.
new, if we're getting new, or it's just the same,
there's a lot of movement in those gold bars. So
Okay.
I'll brainstorm a little bit and we'll see what we can bring
Yeah.
back
Okay.
next month.
All right.
On the payer mix, again, this doesn't change, but again, as the year goes on, this is more meaningful because this is probably where we're going to end the year. And, we've seen as our outpatient services in our emergency department have slowed down, and we can anecdotally point out why that might have happened throughout COVID. Our connection and self-pay, a couple of years ago would have been 19 to 20%, and now we're starting to level off the year at around 17 percentage points for both of those populations. About each month, we've had a favorable payer mix, and that is what I'm talking about. So, I don't have a great answer for you. Most of my opinions would be anecdotal because it's very hard to measure what's not happening, but we are in tune to this and looking for it. I think our Office of Connection Management, as we develop that, you guys approved that during the last budget. I think that will really help us understand more about the behavior of not coming in and getting those services that historically have been occurring.
And we do, is there a way we can see the number for dual eligibility, like Medicare and Medicaid crossover type thing? Because that's probably is the next tier that we need to pay attention. That's our population also as well.
Yeah, we have that, and I don't know how to, because it's not a huge population, it's big dollars, to your point. Let me figure out how we can show that here.
Right, because as we move more
Sure.
and more population health, we need to pay attention to that.
Absolutely. Thank you.
Sharon, before we move off of the connection enrollment, there's just one other piece I think we ought to look at, is the ones that are 64. How many do we have that are 64, so we can start tracking that and seeing if we can, we need to identify those. They're gonna be 65, so we don't wanna lose them. So how many do we have that we really need to be working with?
We actually are looking at that, and Lauren Poe and her group are kind of leading that look.
Okay.
It's about 5% of this total population that would become 65 in the next 2 years.
Okay.
So
Does she
it's
have
interesting that you asked that today. We just looked at that yesterday.
Does she have time for that, or should we look at that with an outside group, like an FMO type thing, so that they can go and sign up people to get ready for the M8 plan that we signing on?
So, yeah, address that, but right now we're just kicking that off. So, again, that kind of ties into that Office of Connection Management and a little bit of how that is, that behavior. For some were higher than budget, so we have an overage there. As I pointed out on the first slide, our CMI is higher. That drives about $1.5 million a month when we have that small uptick in CMI. And of course, we had a slight increase in our overall volume, but we also had a favorable payer mix this month as well. Some of the overages and the expenses are related to some timing issues. We also have some extra COVID expenses, especially in the supplies area. And we have been doing a lot of Joint Commission readiness. Year-to-date, our income from operations is almost $180 million, or about $67 million ahead of budget. Again, that overage really puts us in a great position from a cash standpoint as we get ready for some of these bond projects. And it will really keep my conversation much shorter with the rating agencies as we approach any bond issues. On the non-operating revenue line item down there, below the line, that is where I'm saying that the CARES Act will be recorded. And again, we'll talk about that next month. So it will be a large pickup for year end. Flipping on back to a claim, we did have a slight underage in the claim encounters this month by about 4%. Year to date, that underage, the overage is just about 1% over. And then at the bottom right, our net operating expense per encounter, if you look at that year to date, we're about 5% favorable. So each encounter is costing us a little less than budget. From the claim providers, there's about 485, so you can kind of see where those lie from a specialist standpoint. And we've also, Steve came up with this requested graph. So it's a lot of information, but it makes it really easy to read. So we do have about 21 open positions right now, and about 17 that are offers pending. So a claim, again, this month has not differed greatly from the months prior. They are favorable to budget. They budgeted $1.4 million. The actual was $1.4 million with a budget of $2.9. So we picked up about $1.5 million there. And year to date, they're $12 million favorable to budget. Again, not a lot of variance. There are savings in some of the expense areas, mainly in the salaries, as well as a slight pickup on the top side of the income statement. And then when you put it all together, again, just looking at the year-to-date column over on the right, $148.5 million from operations compared to a budget of $69. So we will be closing the year in a great position. And Roger, I forgot to mention back on a claim, I had to guess last time that we were somewhere between the actual and the budgeted number. Last year, we were right around $36 million, so kind of in between. So there has been an improvement from last year, as well as an additional 20 or so FTEs.
So that begs the question, did we get super efficient this year, or did we highly over budget a claim?
No, it's more about return of volume. As you can see in the top side, we have about a $4.6 million pickup in the revenue dollars that we expect to collect from the business generated.
Okay.
So a little bit of it's related to volume and the way the volume is coming in. It's a higher specialty mix than we expected. So, are there any questions for the month?
That's right.
Not unless his cell phone goes off.
They
Plays the wrong song.
won't let me play my fight song anymore, apparently. Okay, any questions for Ms. Clark? Well, thank you very much. Do we need to accept this or consider acceptance, correct? So I'll entertain a motion to consider acceptance of the 2021 August financial report.
So moved.
Motion by Mr. Fisher. Second by Reverend Emerson. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Sharon. Let's see, item B. Mr. Banda. Your timing is exquisite.
Good morning, everyone.
It's almost like
Good
you knew
morning.
we were finished, right?
Thanks for having me. I'm here to present amendment to the Baxter Vizient contract. And actually, this is our second go-around on this. If you remember last time, the RUC
Oh, yes.
didn't represent their,
We do remember, yes.
it really didn't represent Baxter very well. And so I apologize for that. We went back to them and they come back with a more comprehensive. And actually, Baxter does quite a bit in the small business diversity space, so it was just a bad messaging. So with that said, the contract really tries to gain some savings on this contract that is based on, we have a minimum spend for nutrients that we're just not meeting and will not meet. And so Baxter is willing to lower that from $225,000 to $75,000 a year, so it'd be a net of $150 per year with the offset that we would have to extend the contract for another to 2025.
But 75 is the minimum, you said that we would.
Yeah, so it goes from
Right.
225 to
Okay.
75. So it would be automatic savings if we could get this one done.
Okay, any questions on this item?
No, they did a better job. They did a good job in their explanations, and so I didn't have any. So I will move approval.
Yeah, okay, we have a motion by Mr. Bose, second by Mr. Zimmerman. All in favor of the motion of approving item B, say aye.
Aye.
Opposed? Motion passes. Thank
Thank you very much, everyone. Have a good day.
Dr. Duncan, item C, please. Good morning, good morning.
I am here to ask your approval, both for exemption to bid and for the contract between Mercer and the hospital district. And this is for us to be able to complete the market review that the board accepted as part of the budget. We will start that review as soon as we have approval of this contract and exemption to bid. And during HR committee today, we will speak about the work that we've already completed and the timeline in completing this market review.
Great. Any questions for Karen on this item?
Question, are you on the wrong side? Are you supposed to sit there when the CEO is not here?
Took everything in me not to, but even when Robert's here, I want to sit there, so. Like, move over, Robert.
Move over there and approve.
Okay, any questions for Dr. Duncan on this item? Yes, sir.
Dr. Dunn, does this include executive, all levels of pay throughout the system?
No, it does not. For clarification, it does not include the executives.
Okay,
But all employees,
thank you.
network-wide.
Are they looking at as a job grade, or they look at beyond that also as well?
So we're doing both an equity and market. Equity looks at the employee and compares it to the employee that sits in the same kind of job next to them to ensure that there's equity in payment and in their job function. Market looks at job classes and starts to put that grade, job grade as to when you can, what level you can bring them in, up to what level. And so you start to move that based upon what the market is driving and set your 50th percentile based upon that market review. Those in the past have been done about every 3 years. It's been kind of a cyclic here at JPS, and we have moved with the board's approval to an annual market and equity review.
Okay.
If we decide to approve this, we'll need a two-part motion.
Okay.
Entertain a motion on this?
I'm-
Those two parts? Yeah.
I move approval of the exemption to the bid and for the work with Mercer, contract with Mercer.
Can you repeat that?
Heard the motion by Mr. Bose. Do I hear a second by Dr. Schrader. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you. Thank you.
Thank you.
Thank you, Dr.
I
Duncan.
appreciate it.
Douglas Chung, what you got for us today?
Appreciate it. Yeah, thank you for having me. This is a contract up for approval for FTI program consignment agreement between FFF and Enterprises Minibar LLC and the district. It's an estimated about $1 million annual spend and a total overall spend for 5 years at about $5 million. What this contract does is put a number of our high-cost drugs on consignment and available for immediate use without forcing the district to then purchase a large stock of high-cost drugs that are needed for available use. So what this company is going to come do, there's some technology, and they'll actually put RFID tags on each individual drugs, be able to monitor the expiration dates of all these different drugs. We will then, on our end, monitor this on a monthly basis like we normally do right now through our pharmacy buyer process to make sure that nothing goes expired. We minimize any wastage, but then we also have the products available for our physicians to use. You know, if we were not to do this, this does represent about $170,000 annual savings to our current wholesalers. By going through this consignment company, they get better volume discounts on a lot of these high-cost drugs. So it does have a 30-day out clause and with a prior written notice. And at this point, I'll take any questions if you have.
You had Roger and me when you said the word minibar.
This is a great idea. I have a quick question. So you're telling me currently we burn about $1.2 million in high-cost drugs that get expired throughout?
No.
So where's the cost savings coming from?
The cost savings is coming from this is actually going from a current vendor to our GPO vendor. And if we were to go through our wholesaler that we currently have for all pharmacy drugs, it would cost us about $170,000 more to go through that wholesaler. We're going through kind of a specialized this specialized consignment company that gets better volume discounts because of the amount of high-cost drugs that they particularly purchase, and that's where that $170,000 in savings represents.
All right.
Before rebate or after rebate?
This is, I'm not aware of any rebates associated with this program, but I can definitely look into that, so.
Yes, sir.
Do we have an idea how quickly they would be available? Because some of these drugs, I'm sure I know what you're talking about with P&T, that some drugs just sit there because we rarely use them, but when you need them, you really need them.
Right.
And so that's the question is, how quickly would they get here?
These are on site, so we do set a par level based on our historical usage for some of like the factor drugs and some antivenoms that we have that are, again, high cost. So we do set par levels based on historical usage. So they're immediately available. What this company does then, again, is monitor off-site any of those expirations and then tries to minimize our waste and exposure through their network. So.
When you mention waste and all that stuff, is there packaging differently so that we don't throw away excessive dosage, or what do you mean by
wastage, I mean like if the drug expires while we have it in-house,
right.
Not necessarily wastage. We gave, half of the vial. I think that's where you're going, but correct me if I'm wrong.
Their packaging's different because you can save, but at the same time you throw more away from the other side.
Yeah, wastage, I'm really talking about the expiration of the drug, like I believe Dr. Ziegler kind of alluded to, right? When you need them, you need them, and you have to have them available, but oftentimes there's... correct, yeah, they do have a shelf life, so.
Because I'm more concerned shelf life is one thing, but also packaging. Right?
Sure.
So if they throw more away, the discount's gone.
Sure. Yeah, no, I don't, really nothing to do with packaging. It's more about the availability of the drug here and us having this immediately available. So I'm not quite understanding your question there, but.
I'm just throwing some, if it's 5 ounces or whatever, or 5 milligrams, but if they don't have a smaller one that you can use, they only have 10, and you open up, you only use 5, and you throw 5 away. So it's just as bad as shelf life, right?
Oh, okay, yeah. Yeah, I'm not aware of that kind of being in part of this process where we're using half of the drug in a dose for this particular contract. That's really, once you open it up, right, it's physician discretion then on dosages based on, based on their experience, so.
But you should look at it if the doctor is only ordering it, it's a 10 milliliter vial, and they're only using 5, and they continue to give you 10, then you would be looking at what if your waste is, so you could request that they bring you a smaller
Oh,
dose. So
yes, ma'am.
That's where we are.
Yes, ma'am, we'll definitely take that into account.
Yeah, because I've seen that game playing a lot, because I used to be with what is now McKesson.
Gotcha.
On the drug distribution side. Packaging is where they make the money.
Yes, sir. We'll definitely take that into account for this. And if we can't have any different products switched out for that reason, we will.
Any more questions for Doug? Okay, I'll entertain a motion on item D.
Move approved.
Motion by Mr. Petty,
But then
second
they
by
are
Dr. Schrader.
not
All in
gonna
favor,
Okay.
please say aye.
Well, maybe you ought to tell us
Opposed?
that, because that didn't come out right.
Opposed? Motion passes. Thank you all. Thank you, Doug.
Thank you.
Oh, I missed the whole vote.
Dr. Elliott.
Good morning.
Good morning, good morning.
Hi. Oh, thank you, everyone. Good to see you. I am here requesting approval, two-part here. I'm considering approval to exemption to bid and the Sixth Amendment to the Medical Education Affiliation Agreement for emergency medicine between Integrated Emergency Services Physician Group and Tarrant County Hospital District. This is for an 11-month contract term extension that you see there for the amount of $1.87 million, which is already approved in our FY22 operational budget. This will also align with our professional services agreement that we have ending in September 30th, 2022. And that is our request. Thank you.
Is there, this is part of, we're rebidding that piece of work? Is that part of
Yes.
this? Okay. And they won? Really?
No, this is not that. This is
Oh, not
this.
this, okay.
That is still in process.
Sorry,
There's-
it was there. It was,
I know. There's no decision on that yet.
this is a different.
This is separate. Yeah, this is just to
Sorry,
ensure
okay.
that we have continuity of our medical education and continuity of care as that process is in place.
Got it. Okay. Any questions for Dr. Elliott? It's a two-part motion, so I believe it's a
Okay.
DeBose motion.
I move approval of the exemption to bid and the Sixth Amendment to the Medical Education Affiliated Agreement for emergency medicine. Got it all.
We have a motion by Mr. Bose, second by Mr. Zimmerman. Is that correct? Yes, sir. All in favor of the motion, please say aye.
Aye.
Opposed? And we have one abstention. Thank you very much, Dr. Elliott.
Thank you.
Yes, sir.
I have a question, not in relation to this
Okay.
item. It's just a question, and I thought we were going to get back the information, if it's coming, great, on your office and the efforts being done to reach out to the different schools and universities for us.
Absolutely, absolutely. We can definitely bring that back. We are in process with that right now. We've actually had some conversations even with Fort Worth ISD. We're making some plans that we're trying to put together with regards to the local efforts. And then we are also in the process of our diversity and recruitment efforts that are happening more in a broader sense and nationally based on those things and discussions that we have. We also have a very special Graduate Medical Education Committee meeting coming up very soon where we're actually focused on diversity and residency recruitment. And we have some special guests that are going to be talking about those things so that we can make sure we're aligned with not only what we need to do for a strategic plan here, but also for our ACGME accreditation standards around diversity, equity, and inclusion and recruitment. So we can definitely, we probably need a couple months, but we'll go ahead and work with everyone here to get on the calendar, and I'm happy to bring forward some of those efforts that we're doing and where we are in those stages. Reverend Emerson.
Okay, because I thought that there was an effort also being made to touch and reach out to the programs that the HBCUs.
Yep. Yes, there are. Yes, there are. And that's the process that we are in, and we are doing some of that right now.
Okay.
If there's anything else or other specifics you'd like, I'm happy to bring that forward. But we're definitely in that process right now, for sure.
I have a question, maybe.
Sure.
it's unrelated to anything we do.
Yeah.
But we talked a little bit last year when the residency number was with the diversity and all that stuff. Have we made any progress with anything with reaching out to school like Emory or some other school that have a larger population of?
That's exactly aligned with what Reverend Emerson is saying. We're making that progress right now. We have to also, they're just in that new phases right now in terms of their new classes and everything starting right now. So that's why we're early in the academic year. So we have that definitely in progress. We have a list of schools. There are also national recruiting events. We're also looking at ways to highlight some of the diversity things that we're doing here. But we have actually been doing that over the last 2 years where we've been reaching out to schools, not only HBCU schools, but some of the schools that are traditionally seen even with a double AMC and otherwise and other things in terms of their efforts towards URM, underrepresented in medicine, and those. So we're definitely actively, that's part of our whole long-term diversity and recruitment strategy. And it's a long-term strategy because it takes a lot to move that needle. And so that is efforts that we have definitely are continuing to engage in. And based on the feedback that I got from you in the last couple months, we are definitely actively engaging in that process.
Is there opportunity for us to be at that school and like participate in some kind of banquet or open house or anything like that they have?
Yeah, we're looking at that. COVID has kind of put that a little bit of a hole. Some of them are having some virtual events, so we're trying to see what the best way is to engage with some of these schools. I think we're also wanting to start with some of the Texas areas first, because for instance, some of the HBCUs here in Texas or some of the other schools here too. But also beyond that, we're looking at that. We're looking at also where some of our graduates come, and then we're trying to expand that to see where we can be involved in some of these diversity recruitment activities too. But we're definitely actively engaged in that for sure. Yeah.
Is there someone in your office that's directly assigned to address this?
Yes, there is, Reverend Emerson. So along with working with me, I have my executive director, Diana Singer, and I also have my institutional manager, GME manager, Caroline Diaz, who helps me also with all of this. And she partners with all of the programs. And the programs are also working specifically on this too, and we support them in all of their efforts too, at the program level too. Yes, sir. And if there's anything else you'd like me to kind of be looking at and present, we're happy to bring it
Not
forward.
anything I want you to look at, but what I would like to recommend is that we bring this topic back to the HR committee and make it a part of the review there, because that's where we look at diversity and inclusion.
Sure.
And that's where we should have the follow-up. So I just would say that we move the follow-up to come back to that committee.
Happy to, sure.
All right. And I can give you a moment.
Just to further what Dr. Elliott said, I'm program director for psychiatry, and in the last 2 years now, we participate in virtual fairs with minority student national associations to try and get interest in coming to us for psychiatry. And there's the
Latino, yeah, LMSA is the Latino Medical Student
and there's
Association.
also another one that I know several programs here are involved in, so we are actively seeking out more interest in underrepresented minorities in medicine through a lot of programs like that.
Yeah, in the last 2 years, we've actually participated in the regional fairs for those, the Student National Medical Association, the LMSA is the Latino Medical Association. We've actively participated in that. We actually have branding. We've worked with our communications department too to get those out there, so we're actually very visible in that. It links directly to all the efforts that we've done to really highlight and boost our our presence in terms of social media. Our communications department was wonderful, helping us get our videos and everything together and all the recruitment. So we actually reach out to these organizations that are primarily doing that. And then we're working also at the school level too, that how we're going to work with that. And looking at the pipeline before that, just as you said, working with our local schools to see if we can start to try to build some pipeline programs there. But the efforts are happening for sure. Anything else I can do to help with that? No?
Thank you, Dr. Elliott.
Thank you.
Okay, there being no further business. Oh.
You want mono or stereo?
Mr. Mendenhall, item F.
All right, well, this morning I have 3 contracts in front of you. The first one is with an organization called Master Video. They are the ones that supply support and services to all of our inpatient and outpatient TVs that are in all of our patient rooms, lobbies, and so on and so forth. as well as they provide the programming and distributed antenna system for it. So all of the 30-plus channels that we have going to all of the patient rooms and so on and so forth, it's bundled into this contract. So when you look at all of the pieces that they are supplying support for, services for, plus programming for, it equates to about $28 per month per television. And that's a really good deal when you bundle in the hardware support as well as the programming. So this is a 4-year deal that did go out to RFP. We only had one respondent. And then we have 2 additional terms that 1-year terms that we can go on the backside of this. And it also has a 30-day out clause at any time that we want to write written notice on.
Okay. Any questions for David?
Yeah, so we have, like I said, it's between 28 and 30. I don't remember the exact number, but cable channels that come in to the hospital via the Master Video Network. That cable channel then is put into a distribution panel that then distributes that all across the network to all of our inpatient rooms, the pavilion as well as the tower. But we also have that same network that then is provided out to many of, like the Oncology and Infusion Center and several of our outpatient clinics as well.
Is that like cable, news, and all that stuff? Or does it including pastoral?
All of the above, right? So when you look at the contract, there is 28 channels that are cable news channels, but then there are 7 channels in there that are us to be able to provide. So we have like a Joint Commission channel. There is a Daystar and some other religious TV that goes in there as well. So we can put education on there if we want to. We just haven't been able to do that.
I see. So later on, if we need to, we can put something for certain floor with certain special,
Yes, we always have that ability to put in our own channel and be able to say, this is what's happening at JPS. And if you're on this particular floor, here's some education material and so on and so forth. We just haven't graduated to that yet. So the capability is there. Yes.
Okay. Any other questions for Mr. Mendenhall? Entertain a motion on item F. Motion by Mr. Zimmerman, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you all. Item G.
The next one is 2 parts. It's exemption to bid as well as the the approval for the contract. This is for our ophthalmology team. And so as we've talked in the past, we are moving everything to Epic that we can from a clinical documentation perspective. This is one thing that's still being done in paper and wrongly throughout the entire organization. We kind of missed this throughout the Epic implementation. Now with Epic, we have the ability to bring those eye exams back into and utilizing good forms, good imaging, all those types of things. So the cost of this is just for the implementation. And so when you look at that $110,000 overall, seems like a high number for licensing, but this is really more for implementation. And the fact of the matter is we'll probably use about 1/3 to half of that because our team has already spec'd out what needs to be done. But when we do a contract with Epic, we have to be able to take it at their highest number, and this is their highest number that they've seen throughout all of their implementations. But usually, I don't see us spending half of this for the implementation.
Okay. Any questions for David?
This is a direct API.
It's actually not. It's actually using Epic Hyperspace.
Okay.
And when the ophthalmologists go in, they'll actually be clicking on that tab, just like what we do for cardiology or several of the other specialties that we have contracted with Epic to provide that medical record. But on the back end, if someone presents to the ER for Dr. Schrader, he'll be able to see what's been done in that ophthalmology clinic as well as all the other clinics that are happening. But the eye docs that see it looks like their own space, but really what it's done is it's tying it to the entire global medical record that we have within Epic.
Oh, okay, so we don't have to go through the
No APIs
redocs or anything like that?
Right, exactly.
Okay, this is a 2-part motion.
Thank you. Move approval of the exemption to bid and the implementation of the Epic system for the ophthalmology group.
I second whatever she's saying.
Motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, David. Item H.
So the third contract, the final one for me, is with the district and MX Technology. MX Technology is a a Texas company that works underneath the Texas Department of Information Resources, the Texas DIR, which gives us global purchasing within the state of Texas as a state agency. So what we are working with MX to be able to do is work with our Kronos system. And Kronos obviously is a global company. They are now branded as UKG, so if you've turned on any sporting in the last 6 months, you've seen someone with a UKG logo, whether it's in golf or tennis or whatever's going on. They are the premier with ADP and a couple other systems doing workforce management. We use Kronos for all of our time clocks and all of our payroll. This right here is that we're looking at with Kronos Dimensions is an entirely different set of analytical systems so we can manage our workforce better. It will give our inpatient, or actually not our inpatient, but our command center group the ability to be able to see schedules across the entire district. So what does that mean for us? When Dina Dent and Crystal Gandhi are looking for resources that maybe need to go into the ICU for critical care, we don't have the ability right now to be able to see who across the entire organization has those credentials or has shifts that are available that they could then come in and man our ICU. So what do? They send out emails, they send out spreadsheets, they send out forms, they send out things, and they try to manage all of that really paper-based. What Kronos Dimensions will allow us to do is see the entire workforce from one pane of glass, so that then we can run analytics on whether or not we need to flex staff, whether or not we need to hire more staff depending on surges that are coming through, and then what abilities do we have to be able to move staff around that have certain credentials to get into some critical care areas when we need to. So we're really excited about this particular product because I think it's going to change how we do workforce management from now on.
Okay, any questions for David?
Move approval.
A motion by Mr. Bose for approval, second by Mr. Zimmerman. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, David.
Thanks, guys.
Now we'll turn it over to Chairman Petty to give us a planning committee.
Thank you, Mr. Chair. We met with the Tarrant County Commissioners Court yesterday, gave them an update on the process. I introduced our overall steering committee effort, the purpose for it, our schedule. Turned it over to Derek, who then gave a very detailed explanation of our schedule and the process that we are utilizing to prepare for RFPs and RFQs. We noted the work that Daphne had done, making sure that the district was going to adhere very specifically to RFP and RFQ process. Made sure the commissioners understood that that process is one that JPS has always adhered to and will continue to. Our presumption from that is that the commissioners will then hear those presentations when they're presented to them, and they won't necessarily have a yes or no vote on RFPs and RFQs, but obviously they would be hearing about any contracts and approving contracts after those are issued. So the main purpose was to make sure that they understood that we've provided a mechanism for them to be a part of this process. Mr. Manius was at the last steering committee meeting. We're gonna have ongoing invitations for him, for the Commissioners Court. Those are open meetings for them. They're welcome to come. Anything they need, we're happy to provide it to them. So really just to outline where we are today, there's significant discussion on the topic of medical home. And Derek mentioned that at our next steering committee meeting, we may be far enough along to start talking about locations for the first medical home. That's an item of significant interest, as you can imagine, to everybody, as to where that medical home might be. But we also pointed out the work that has been done by Guidehouse to date, which was to go back and compare the Blue Ribbon Committee data, which concluded the broad areas that those medical homes might be appropriate for based on the data we gathered 5 years ago, and updated all that data and added new variables to that data that really gave us the ability to look at those same elements with new thought processes that, again, Guidehouse, as you know, was the consultant that provided the Blue Ribbon Committee data. They've really made that a lot more robust process. And when they did that and they looked at the variables applied to the old model and updated the old data, they found basically the same exact thing. Still looking at the same general areas the same needs without really much deviation at all from where those medical homes probably should be situated. So part of what staff is doing when they evaluate those medical home locations is to look at more than just demographic profiles, but to try and look at some of the things that we've talked about as a board when we talk about sort of the evolution of our clinic model and what that needs to look like. One of the variables being us being able to bring in new revenue streams and being able to focus our efforts on not just a cookie cutter approach to medical homes, but a unique approach that reflects the neighborhood and the area needs of that particular market, so that we have the ability to adjust that and hopefully bring in additional patients and additional revenues. One of our goals is to try to obviously capture a significant Medicare, Medicaid population that today still has no PCP. Many of those are dismissed from Baylor, from THR emergency rooms every single day. Those are potential customers, patients for JPS. So our goal is to make sure that this process takes into consideration a much broader set of variables when it comes to why this location makes sense over another location. So it may take a little longer than what some would like, but we did assure the Commissioners Court that that is a priority item for us, and that first medical home location is going to come about quickly, and we should be in a good position to capitalize on that, given JPS's sort of new ideas about how those medical homes should operate. So our next meeting, Karen, is when? October 1st. So coming up in a week and a half. So anyway, the process is going great. Steve, thank you for your presence. Dorothy, DT, Roger, all of you. It's a Herculean effort. It takes a lot of time.
A lot of work.
We go through a lot of information. But we also want to make sure that we're able to bring all that information ultimately forward to the board so that we can have input on these items. So part of what we're doing is just making certain that items are being prepared accordingly, and that they're going to be processed in a manner that makes the board a part of that process. You'll begin seeing RFPs and RFQs appear on the portal probably within the next week. So keep an eye on those. We'll send emails to notify you that those are available so that you're in the loop. And anytime we need to bring additional information to you. Karen, did we put Derek's presentation to the Commissioners Court on the portal?
I don't remember. I know we said that we would.
The information that was presented was put on the portal, but not the presentation.
Okay, well, his slide deck, though, was on the
Yeah, the
portal.
slide
Okay,
deck.
as long as his slide deck. I mean, that's a good thing to go take a look at, because that really summarized the work that we've done and kind of what's headed, where we're headed over the next few months. So look that up. If you have any questions on it, let us know.
Trent, I got a question. So when it comes to reviewing the RFPs and the RFQs that come in, is the Commissioners Court looking at those, or I'm just trying to go back to what you first said?
No, they're not. I mean, we're going to observe the process that we've always observed at JPS relative to RFP and RFQ process. And that is, once RFQs are released, then that information is public. Then when we begin receiving proposals, those proposals are received by staff only at JPS and Derek and his team. So they're the ones that put together the review process for those RFPs to make a recommendation. That's not a process that we're a part of.
Right,
It's not
okay.
a process the Commissioners Court's part of. Now, once the recommendations are made, then there may be questions or additional information associated with those recommendations that would come back to us and/or the Commissioners Court, and we'd respond to those accordingly, but not to the extent that we'd be looking at a different level of review for the proposals than what we've always observed.
And as Zim requested, we'll see not just the data from the selected or the recommended, but we'll see the data from the other,
You will see
the
not
top 2 or 3 submissions.
That's right. You will see the RFP itself. You'll see the criteria that was applied to the RFP. You'll see the scoring recommendations of staff, and you'll be able to ask any questions relative to that entire process once that comes to the board.
Thank you.
Trent, and I to the total board, probably one of the major goals is location.
Sure.
And I would hope that we would really do a good job as a board of looking at that, because it could be political, but we need to some kind of way get it where it's based on need. I don't have the answer for that, but some things are just running through my mind if we're not careful. Because the other thing is, we just opened up a new medical home, basically. I'm not so sure if I was to do it all over again, I would have opened that medical home as it was open. I know there's a need out there, but what I'm saying is doing by the cookie-cutter approach, that we want to make sure it's designed like all the others, where the next medical home could be actually located close to an existing medical home, but it's providing and addressing that area need that would fit that medical home. And so I would hope we would look at all of that.
Yeah, and that's a great point, Ralph. And I think that there's not any predisposed ideas about where those are going to be at this point. They have been, and Judge Whitley specifically asked if our process was going to reflect one design-build contract, for example, to build all of them. The answer was no. I mean, we intend to be able to customize these. Now, we do want to make sure that we have branding consistency. We want to make sure we have some level of architectural consistency. We're not intending to go build completely different, facilities for each location. But we also don't want to be limited to one particular design that's a copy of what we did at Northeast on all the projects. I don't think that's what we're headed toward, and that's certainly not what the staff has contemplated when they've put together the RFPs. So I think what we want to be able to do is bring all of that data relative to that location selection process to the board. And the board obviously is going to make the decision as to whether or not we move forward with one location or another in terms of the recommendation of the Commissioners Court. So whether that comes before the Joint Finance Planning Committee or it comes before the entire board, the board's going to see that. And we're going to have plenty of opportunity to vet that, ask questions of it. We may decide in some cases to send it back. We may actually want to go back and take a look at different variables over and above what were looked at in the original process. So I don't think there's any constraints whatsoever considered at the board level based to that selection process. We need the board to feel very comfortable that they've had adequate vetting, they've been able to ask questions, that the priorities that we've talked about are being met, the location criteria are vetted correctly. So we don't want that process to be anything other than completely transparent and take as much time as we need to so that the board's comfortable with the recommendation.
Trent, Ralph, on looking at the needs for that area, I think how they looked at that was broader than it was very broad. And I think maybe that's a piece that we need to share more with the board, because they looked at the community assessment to see how those needs identified, looked at in that area, people that live there, what was the need for those areas. So it was a little bit broader than, and then that's how they identified. And I think that's the piece that if we share a little bit more of that design that we just got at our last meeting, how they looked at and evaluated how everything should be, their recommendations are made off of. It's a broader piece, and I think that's a piece that we need to share with the full board.
So why don't we do this then? Why don't we ask, Steve, why don't we ask, as a function of this joint committee, to have staff and Derek come back and give us the detailed report relative to those additional data points that were collected relative to their process. We can do that before there's ever a recommendation of location. We can get that back to you by the next meeting.
The data, it was actually pretty striking how close it was to 2 or 3 years ago to the same general areas, but then overlaying social determinants of health and everything else into it. And then we even asked them to look at food insecurity, and there were two that we had.
That cell phone ability for, for mobile devices, internet access.
Yeah, internet, transportation, food insecurity, further overlays to maybe make it a little more clear for us to identify where it should exactly go.
Actually, then that ties in when we were doing the infant mortality review.
Yes.
And the community access that were out there.
Yeah.
One of the things I know this probably may not be in the bond scope, but when you look at if the medical home area becomes the priority, okay? Is it feasible that maybe, I'm thinking about a couple of things that's coming up. One of them affects Dorothy's area. Can a medical home, an existing medical home, maybe be readapted to address maybe a particular, we might say this area has this need, but maybe we might save some dollars in building a new. I say that because when I look at what's taking place in the community, there's major development coming forth in the Stop 6 community. And I can tell you now, they're going to be coming, knocking on our door about that medical home in Stop 6.
Yeah.
But also, you got major development coming up in Como.
Sure.
And so my thing is, as opposed to, say, I'm building another medical home down the street, maybe the existing can be expanded or adjusted to address that.
Yeah, that's a great point. And I think that's where we want the board to be the author of the ultimate selection process, so that we've looked at all of those variables. And we may find that there's existing medical homes that are in a great location, but they're not adequate to provide the services that need to be provided, or that the service dynamics have changed in that area. And we need to look at a different approach to making those service concessions.
To accommodate transition of care or something like that.
Yeah,
also as
absolutely.
well.
So Karen, I mean, we can bring Derek's report back to next meeting, maybe have, is it Leslie? Lindsley,
yes.
maybe have Lindsley come?
Yeah, we can set that up. I think that meeting is October 14th.
Okay.
The July meeting here, we can talk about on that. I hope to bring a recommendation, preliminary recommendation.
It is.
October 1st, executive
Okay.
session. So,
Yeah.
however we want to do that.
Yeah, let's just make sure that whatever we do, it's accompanied by that presentation by Lindsley, so that the board can see what all of these variables are that we're now measuring. And then to the extent that there are others that we haven't looked at, that we take a look at that and bring it in. And I realize that potentially could cause a delay, but I would much rather make sure that the board is comfortable with the overall direction and the analytics that we're applying to it before a recommendation gets made. I mean, there's clearly, there's expectations, and there is, I don't know, frustration is probably not the right word. There's a lot of people that think we should have already built $1 billion worth of, improvements. And one of the points we made yesterday was, look, it's not that we've been doing nothing. There's been a whole lot going on at JPS, not only to prepare for the bond expenditures, but just looking at our own facility needs today in light of making sure that we're not duplicating cost and that we're not putting, good money after bad on existing facilities. So, and all that is the IRMA process, and we've all been deeply involved in that now for the last 6 months. So if we conclude that there are either variables that have not been adequately vetted, or that there are new conditions that staff hasn't considered when it comes to those locations, we need to make sure this board has an opportunity to give input on that. To the extent that means we have to delay, it won't change the fact that our RFP, RFQ process moves forward, because all of these things are components of ultimately the facility itself, not necessarily architectural design and parking lot access and all those things. But it will give us the ability to make sure that when it does come down to establishing the specific program for each of those medical homes, that we've given that a very thorough review, so that we've addressed some of those concerns. And we pledge to make sure that the board has that opportunity on every one of these things.
I get the board okay with this. I think it would be helpful to ease some of the concern in the community if Derek and his group could make some presentations in the community.
Okay. At the clinics or at different locations in the community?
Let me be more candid with this. I'm part of a pretty large ministerial group in the community. And I think what would help if he made a presentation before them. So then those pastors can talk to their congregations.
Okay. Yeah, that makes sense.
And I'll talk to whoever to see about trying to get that set up.
Yeah, I think that's fine. It wouldn't just be Derek. It would be Levis. It would be our whole
Sure.
team.
Yeah,
There's
right,
a lot
sure.
of dimensions to what
Right.
Broadus is kind of spearheading that, but we want that whole team there to have that kind of
Yeah,
discussion.
good community communications plan.
Yeah.
Yeah.
Good point.
That work for you guys?
No, I agree, and we had a conversation yesterday, just to your point, Reverend Emerson, about at what point do we bring in the community and how do we identify what that community is? There is already a lot of work with our communication team and with case strategies around ensuring the diversity spend and that we are meeting that goal. So there are some expos that have started for those vendors and some of the business chambers, but we will reach out to members of the board and also the chambers to understand who in the community we will start to bring in as part of that discussion when we will do that.
Okay.
Yeah, we've learned a lot already. We've learned things about our diversity program from the bond process that we've said, look, this needs to be integrated into the overall JPS process. These are not just elements that we're considering for the bond.
Right.
These are things that really help JPS meet our overall diversity needs. So that's part of what we're doing, is making sure that this is not isolated in application to the bond program.
Okay.
Okay. Thank you, Mr. Chairman.
Yes, sir.
All right, we have nothing in closed session, so therefore, if there's no further business, we're adjourned.
I didn't know if this was a part of finance or not, but